Good morning, Sages. It's an honor to present here. This is Heeji Shin from Asan Medical Center, Korea. Today, I'm going to present about propensity score matched analysis comparing laparoscopic and open pancreaticoduodenectomy in elderly patients. We have nothing to disclose. According to data released by WHO, the average life expectancy is 71 years old in 2015. Senior citizens over 70 years old in Korea make up 14% at present. The ratio is expected to 40% by 2050, so we defined elderly by over 70 years old. Laparoscopic PD is doing by multiple high-volume centers lately with good outcomes. But the safety and benefits of laparoscopic gastrectomy and colorectal surgery in elderly has been emerged by several articles, but not many studies done of laparoscopic PD in elderly. In this study, we compared perioperative and oncologic outcomes between laparoscopic PD and open PD in the elderly population by using propensity score matched analysis. This is a single-center propensity scoring matched case control study from January 2014 to June 2017 at Asan Medical Center, Seoul, Korea. In our center, the proportion of laparoscopic PD has been rising, and it takes almost 200 cases per year in 2017. There were 1,693 patients who had consecutive PD with periampullary tumors in those periods. 1,157 patients were excluded who are younger than 70 years old. 110 patients were excluded by exclusion criteria, which is vessel resection, adjacent organ resection, robotic PD, previous major abdominal operation, and double primary cancer. So total 326 patients underwent PD for periampullary tumors were included. They were divided into laparoscopic and open PD groups and analyzed. To control selection bias, the comparative study conducted using by one-to-one propensity score matching. We defined postoperative outcomes by Clavian-Dindal classification. Major morbidity was defined by Clavian-Dindal classification grade 3 to 5. POPF, which is the most common postoperative complication, were defined according to 2016 ISGPF grading. We defined POPF with antibiotic therapy more than 10 days after surgery and peripancreatic fluid collection with infectious sign as POPF grade B, as it shows clinically relevant change in management. We also defined clinically significant POPF with grade B and grade C. Of the 326 elderly patients, we divide to two groups with laparoscopic and open PD group. We compared two groups with demographics and perioperative findings. In those variables, patients with laparoscopic PD group had lower BMI, lower preoperative drainage, and more pancreatic tumor and longer operation time. We also compared in-hospital complication graded by Clavian-Dindal classification. There was significant difference of overall complication, but no difference of major morbidity. The most common postoperative complication was POPF, with a higher frequency in the open PD group. The table shows surgical complications that after colorless ascites, POPF, gastrointestinal, cardiopulmonary, and wound complications were higher in open PD group. To control selection bias, we used one-to-one propensity score matching by adjusting those variables which could affect the results. In result, all baseline parameters were balanced. The operative and perioperative outcomes after matching are summarized here. The laparoscopic PD group had a significantly longer operation time than open group. Interestingly, the mean number of analgesic injection administered was significantly lower in laparoscopic PD group. As we know that postoperative complications were significantly high in open PD before matching, the same result happened after matching. POPF, which make up most of overall complications, was significantly lower in laparoscopic PD group. Clinically significant POPF, which includes grade B and C, shows a higher frequency in open PD group. To know oncologically feasible, we compared oncologic outcomes and survivals. Oncologic outcomes and 3-year overall survival and disease-free survival was not statistically different between two groups. In summary, we evaluate the result to determine whether the survival data justified the implementation of laparoscopic PD in geriatric oncology. Adequate lymph node and resection margin was achieved. The result shows that there are no statistical difference of 3-year overall survival and disease-free survival, which means that operation technique doesn't affect the oncologic outcomes. Laparoscopic PD had lower overall complication with lower POPF and lower gastrointestinal complications. There were some studies that laparoscopic surgery manipulate bowel less than open surgery. Although clear evidence-based data on anastomotic healing are still lacking, the lower rate of gastrointestinal complication might explain less overall complications and POPF in laparoscopic PD group. Also, laparoscopic PD has lower cardiopulmonary complication. It might be explained by smaller incision, thereby reducing pain, which is evidenced by our study that less use of analgesics in our study. It will facilitate early ambulation, easier deep breathing, and could lead to less cardiopulmonary complication and also less wound problem. However, our data are not adequate for demonstrating a significant benefit of less pulmonary complication in laparoscopic PD. Therefore, a larger core study would be needed. To conclude, even though PD is one of the most complex general surgery operations, our observation indicated that laparoscopic PD in elderly patients has fewer incidents of postoperative complications and is oncologically feasible. Therefore, we believe that these results justify the implementation of laparoscopic PD in the feasible treatment option for selected elderly patients with periampullary tumors in a large volume center. Thank you for your attention.